Good morning, everybody. Thanks for being here today for the grand rounds, and we are very excited to have our own expert in the mitral valve percutaneous intervention, Dr. Amar Krishnaswamy. As you probably know, Amar is the head of our cath lab as well as the section head for the interventional cardiology. He did his medical school at Yale and then did his residency at Hopkins, was a chief resident there, and then came here and worked with us, and we are very fortunate to have him here. This is his expertise to have mitral valve intervention. As you know, we are doing now a lot of different things in the OR and in the cath lab with mitral valve, including mitral valve-in-valve, mitral clips, and Dr. Krishnaswamy is going to go through all these different things that he has contributed tremendously. So we are very fortunate to have Amar as our guest today for the grand rounds.
Thanks, Dr. Kapadia. Thanks everyone for coming, both in person and virtually. I know the talk title said mitral and tricuspid, but I think that there's been so much of a proliferation of things we can do in the mitral space in the last few years. I thought I'd cover just the mitral valve therapies and try to give everyone an understanding of what all we can do. I have no financial disclosures. So what I'd like to cover as targets for transcatheter mitral therapies in 2024 includes primary mitral valve regurgitation, secondary valve regurgitation. What can we do with native mitral valve stenosis or calcific mitral valve disease in combination with MR? Mitral stenosis or regurgitation after prior surgical mitral repairs, and what can we do for degenerated surgical mitral prostheses, sort of mechanical and prosthetic, bioprosthetic. I'd like to do this by providing sort of a practical understanding of what is currently possible for patients through transcatheter approaches via case examples. I think everyone has a pretty good understanding of what we can do in the aortic valve space. But again, the mitral valve space is a lot more varied and the spectrum of disease is very different. To be exhaustive about the data, of course, would be tough in the time allotted, but I'd like to highlight some of the key supporting data. I think it should go without saying, I hope, that the cases that I'm going to show you really include and reflect a collaborative approach between nurses, advanced practice providers, and fellow and staff physicians in not only interventional cardiology, but imaging cardiology, clinical cardiology, the ICU, cardiac surgery, and cardiac anesthesia. So truly a group effort and a yeoman's effort in that regard. So starting with primary mitral valve regurgitation, impossible to talk about mitral valve regurgitation at Cleveland Clinic without talking about what our surgeons have accomplished, certainly moving from the earlier ages of sternotomy to endoscopic robotic valve repairs, and between about a 21-year period to have treated more than 2,000 patients in this way with a repair rate of nearly 100%. And national averages in surgical registries are, give or take, 40% in the best of circumstances on average. And to do that with an operative mortality of 0.05% is truly unheard of, right? And if you think about it, these are the type of results that MitraClip or edge-to-edge repair were initially compared against. And that's why when you see that in the ACC valve guidelines, the MitraClip is really reserved for patients at a high or prohibitive surgical risk, giving it a Class 2A indication. The caveat, though, is that these were data based on an early trial of the first generation device that'll become relevant in a second. Back in 2009, the high-risk sub-study of that trial that showed benefit of the clip only in those patients, and then the ultimate FDA approval 11 years ago. But if you think about that in the contemporary era, if you just look at the papers published on MitraClip between the time of FDA approval and now, there are over 2,000 papers. And so the academic data there that's supportive of percutaneous therapy is quite substantial. And if you look at why that is, first, we have different devices. So that first clip in the top left is what we started with. We now have 4 devices, different widths, different lengths of the arms. We have a second device by Edwards called the Pascal device, again, as you see here, available in 2 different sizes. And perhaps as important or more importantly, we have much better imaging. And I just give the call out here to Serge Harb and Rhonda Miyasaka in our imaging section, who have been truly worldwide pioneers in advancing 3D multiplanar reconstruction, or MPR, in technically guiding these procedures. And most of the images you're going to see over the next 45 minutes are from that kind of imaging. So if you then look at the most contemporary evidence that we have, this is called the Expand G4 registry, about 1,000 patients treated with the most recent iteration of the MitraClip device. You see here, as opposed to the earlier trials, 98% of patients left with 2+ or less MR, 91% with 1+ or less. This is substantially better than those early trials. I've put in that red box there. Only 8% of patients were treated using that first generation size of the device, the NT. So we're using the more contemporary devices more appropriately, I would say. And ultimately, these are all high surgical risk patients, and yet a 30-day mortality of just over 1% with sub 1% other risks. There are always limitations to registries. These are not all comers. These are site-provided echoes. But again, demonstrates that there's probably some foot to stand on in terms of how good contemporary edge-to-edge repair can be. The most recently approved device was the Pascal device. This was a CLASP 2D trial comparing the CLASP from Edwards to Abbott's MitraClip. You see here similar efficacy, about 98% of patients on both sides of that graph with moderate or less MR out to 6 months. So how do we put all of that together in how we're treating patients in 2024? This is a 74-year-old gentleman with severe degenerative mitral valve regurgitation. You can see here the grasping plane in the 3D down here in green shows you the area of P2 segment flail. Of course, torrential mitral regurgitation as a result of that pathology. Normally, this patient would have surgery here every day of the week. This patient was randomized to MitraClip as part of the primary trial, which I'll get to in just a few slides. So we brought the patient to OR81. You can see here again the type of procedural guidance we have. We have the clip there, as you see here, oriented at A2, P2, underneath the area of mitral pathology. We can favor the anterior leaflet, grasp onto that, so we have a nice grasp on it. We can move over to the posterior leaflet, grasp that, and now our clip is closed. Now, if you look at the result of this, we still have sort of mild, maybe 1 to 2+ MR. And truly, 5 years ago, we might have been okay with this result, but not now. So you can look here again, based on the imaging, you know there's that MR just slightly lateral to where our clip is. So we can simply let go of the posterior leaflet, clockwise the clip just a little bit to grab more of a bite on that P2 segment of pathology. And then you see here what truly I think you can call a surgical-like result, really no more mitral valve regurgitation there. So if we look at this primary trial, this is an NIH-sponsored trial. Dr. Gilinov is the principal investigator. It's a prospective, multinational, open-label, randomized trial using a superiority design, really with a primary aim to evaluate the long-term effectiveness and safety of surgical valve repair versus edge-to-edge repair, with important secondary and tertiary aims to understand adequacy of MR correction, as well as patient-centered outcomes. The primary endpoint is a composite of all-cause mortality, valve reintervention, more than moderate mitral regurgitation, up to about 3 years, with important secondary outcomes, again, that include efficacy of MR reduction, as well as patient-related quality of life measures. Inclusion, this is any patient above the age of 60. Surgical risk is not a decision point. They should have primary MR. Perhaps the most important inclusion, frankly, is that they're anatomically suitable for percutaneous therapy or surgical. In truth, they're all, as we've shown from the CCF data, they're all suitable for surgical repair. The ugliness of valves that Dr. Gilinov, Dr. Malis, the rest of the mitral team treat is really extraordinary. And so, most importantly, we tend to exclude patients on the percutaneous side because we know we won't get a surgical-like result. The exclusion criteria are, I think, relatively straightforward. The patient doesn't have degenerative MR, or we don't think it's really a good idea, or they need other surgical procedures. Moving on then to secondary mitral valve regurgitation. Really, the primary mode of therapy here is transcatheter edge-to-edge repair. The COAPT trial was the most important sort of seminal study in this regard, randomizing patients between edge-to-edge repair with a MitraClip device and heart failure guidelines-directed medical therapy. You can see here out to 5 years, as published recently with Dr. Kapadia as one of the authors, that the improvements in both heart failure hospitalization as well as survival that were noted out to 2 years were sustained out to 5 years. And so really established edge-to-edge repair in the guidelines then, in the most recent 2020 guidelines, as a Class 2A indication for patients with chronic severe MR related to LV systolic dysfunction. I would just state parenthetically that surgery in this group of patients has a more limited recommendation than, of course, the primary MR group with a Class 2B indication for those patients. So how do we treat these patients? This is a 62-year-old with ventricular dysfunction, and you can see here a pretty wide area of MR at the A2, P2 segment right here in the middle of the valve. Systolic flow in the pulmonary veins is blunted. The hemodynamics show substantial abnormalities, a V wave of 65 millimeters at a blood pressure of 110, mean LA pressure of 28. These are all things that we think about, especially in treating secondary MR patients, because we want to look at them and look at their treatment for a multimodality assessment to optimize their outcome. So you can see here after one clip, there's less MR, still significant, probably at least 2 to 3 plus or 3 plus. The hemodynamics are much better. We see the LA V waves have come down to 25 from 65. Pulmonary veins are better, but they're still blunted. Gradient is pretty insignificant, 3 millimeters. And we can see we still have 2 large orifices on either side of the clip. So this allows us then to be better about our result. We know looking at all of these things in totality are going to provide the best near and midterm outcomes. So we put in another clip, reassessed everything, had the ability to put even a third clip, and you can see now sort of minimal residual MR, still good orifices. The pulmonary veins are now normal. All of these little factors are incrementally better for patient outcome in different trials. Mitral stenosis gradient is minimal, and the V waves and LA pressures are still elevated, probably reflective of some systolic and diastolic ventricular dysfunction. A bit of a different story, but I think to demonstrate the spectrum of disease that we can treat and patients we can benefit. This is a 68-year-old with a non-ischemic cardiomyopathy, EF about 35%, a CRT-D in place, numerous VT ablations actually. Initially admitted with acute decompensated systolic heart failure, ultimately discharged on heart failure guideline-directed medical therapy and optimized. Unfortunately readmitted within a month with worsening heart failure again. Came to the intensive care unit with cardiogenic shock, treated with intravenous therapies, sent to the nursing floor, unfortunately developed AKI. His ARNI and Entresto was held, continued increase in creatinine. I think a very typical story. All of us have taken care of this patient numerous times. Went back to the ICU, SWAN numbers again, not ideal. So if you look at the echo, not the worst, but at least moderate ventricular dysfunction, severe secondary MR, of course. Right ventricle looks good, and I think RV dynamics is an important thing that we discuss with our heart failure colleagues in trying to understand which of these patients we can benefit. As you see here, significant mitral regurgitation in the middle of the valve and extending out laterally as well. Obviously, this patient didn't have a lot of great options. So we brought him for clips. You can see here after 3 clips, really sort of trivial to maybe at the worst mild residual mitral regurgitation. Confirmed by the surface echocardiogram. Importantly, over the next 5 days, you see a reduction in his creatinine, actually normalization of his kidney function with this. And he was seen in our heart failure clinic earlier this spring with 18 months of follow-up. And I can read it to you. He continues to improve with GDMT optimization after TMVR, NYHA class 1 to 2, doing extremely well, has remained well compensated, no further admissions. And so this is a smaller, more niche group, but again, patients that are seen often in our intensive care units. These cardiogenic shock with MR patients. So this is about 4,000 patients in the ACC TVT registry who underwent a mitral TEER in that setting. You can see here in these right bars, those patients who had a successful TEER procedure, defined as 2+ or less MR, no complications, etc., had a 1-year mortality of about 35%. Any of you taking care of patients in the ICU know that every single study on cardiogenic shock, no matter what the etiology, the 1-year mortality is 60 to 70% every time. And so 35% 1-year mortality is actually a pretty substantial improvement, and you can see here, certainly better than those patients who had an unsuccessful device. At 30 days, the MR reduction was sustained, 90% of patients with 2+ or less MR. Importantly, the majority of these patients did have degenerative MR, a lot of MIs, papillary muscle pathology, etc., but about 40% had secondary MR. When we look at other options that we have in the functional MR group, indirect annuloplasty is one to mention. Here's a 67-year-old with an EF of 35%, functional MR, of course. This is a Carillon coronary sinus annuloplasty device. So this is a band that sits in the coronary sinus, which is very closely apposed to the mitral valve annulus. And so by cinching the coronary sinus, it reduces the septal lateral dimension, improves the coaptation of the mitral valve leaflets in FMR patients. So this is the coronary sinus venogram. We do this procedure by the internal jugular vein. It's a bit hard to see this fluoroscopically. This is the band in place, but it has affected a reduction in that coronary sinus dimension, or I should say mitral annulus dimension, as you see there. And you can see here the pre and post mitral regurgitation. Now, the device is approved with the CE mark in Europe based on, again, as in Europe, relatively small registry trials and a very small randomized trial. Nevertheless, in those studies, you see a reduction in regurgitant volume on the left, and on the right, a reduction in LV volumes. The red is the very small control medical therapy arm of the randomized trial, which is why it's worse than the other bars. But in the US, we have the EMPOWER trial. The national PI of this study is Dr. Kapadia. Drs. Gilanov and Starling are on the steering committee of this trial. So looking at about 300 patients randomized between the Carillon device and control heart failure GDMT. An important facet of this trial is that out at 6 months, whether or not a patient got randomized to device or medical therapy, if they have severe MR still and symptoms, they can then seek another commercial treatment, whether that's a MitraClip in combination, whether it's an LVAD, whatever surgery, whatever it might be. And so this it kind of burns no bridges, I guess, to enroll a patient in this trial. Importantly, over time, what we've learned is that this is beneficial not only in the mitral regurgitation space, but also in patients with ventricular dysfunction and dilation. And so on the basis of a few smaller studies, this the entire hypothesis of this trial has changed a little bit over time. And so not only are we taking patients with mitral regurgitation, but we're actually even taking patients who have just 1+ MR or more, but who have LV dysfunction and ventricular dilation, because we know that in these patients in the longer term, this annuloplasty device can affect changes in ventricular remodeling. So again, something to think about not only for your MR patients, but also your LV dysfunction patients. What about transcatheter mitral valve replacement? Well, we know that in patients, this is an analysis of the COAPT study. We know that in patients for whom we don't affect a good edge-to-edge repair, we don't do them a lot of favors. And so we've gotten a lot better at understanding what is the type of mitral pathology that we can treat well with edge-to-edge repair. That's still our default usually. Or where do we need to seek a different type of therapy? So wide origin FMR is just one of the things that is often a difficult target for edge-to-edge repair. You can see even in this 3D that there's a coaptation defect really all the way from the anterolateral commissure to the posteromedial commissure. You see mitral regurgitation all the way through the coaptation line in the 3D, even in this commissural view that you see on the top right. This is not a great valve. We can't zip up the entire thing with clips or a Pascal device. So that's the type of patient we analyze for a transcatheter mitral valve replacement. This one particularly, this is one of the trials in which we're involved. This is called the InnoValve. It's kind of an interesting design. You see these little fans, I guess, or fan blades. These are used to go into the ventricle, rotate around the subvalvular apparatus. That's what keeps it in place, and then we expand the valve into place. So you can see here, these are little fans open in the ventricle. They'll twist around the subvalve apparatus. You see that happening here on the 3D MPR. And then once the valve is in place, sort of a nice valve here without any significant mitral valve regurgitation. As this implies, as we're screening patients for these, the subvalve and specifically the ventricular outflow tract is an important exclusionary criteria for these, because if you push the anterior mitral valve into the LVOT, that can cause major issues. We'll get into that in a moment. This is another device similar but different. This is a scaffold that we wrap around the subvalve and place a balloon expandable valve inside of it. This is the M3 by Edwards. You see here the scaffold going around and around and around the subvalve. I haven't shown the echo, but you can imagine this is quite an effort on our imager's part to show us this happening, that we're properly getting around the cords and the papillaries. Once that's in place, we can put this balloon expandable valve in, and then again have a nice looking echocardiogram at the end of it all. This is a particularly busy slide. You're meant not to look at it very closely. That's why the font is so small. But just to say that this is a huge arena of development, both in pre and clinical trials now, early feasibility studies both in the US and outside of the US, and larger registry trials, including some that are looking at failed edge-to-edge repair, now bringing these patients. So a lot of different devices that are currently in development. We're of course involved in a number of these and sort of choose our patients specifically based on the anatomic criteria that are important for that particular device. So to step back for a minute, how do we look at our patients with secondary mitral valve regurgitation? A lot of things here I didn't discuss, but importantly, the first line is always these patients see our heart failure specialists, understand whether the guideline-directed medical therapy is appropriate. Usually it's not. Usually it has to be titrated. We also look at their coronary arteries. Is there any option there for revascularization that can help with the secondary MR? And we liaise with our EP colleagues about resynchronization therapy or AFib management as well. Generally, about a third of these patients will then reduce their MR to moderate or less. That's why we start here first. And in those patients who have been successful with those therapies, we might consider for a coronary sinus annuloplasty. Those who have continued severe secondary MR, that's when we're thinking about these various devices that I've discussed over the last 10 minutes. What can we do for native mitral valve stenosis? This really it plagues patients, it plagues us as clinicians, our cardiac surgeon colleagues hate it. No one likes native mitral valve stenosis. So a couple of options that we have. One is a valve in mitral annular calcium or valve in MAC. So for example, this is a patient with, as you can see on the 3D echo, pretty circumferential annular calcium. The CAT scan, of course, confirms that, as you see there. And you see with a TAVR prosthetic inside of that MAC that we still have a good space in the ventricular outflow tract. So this is a patient, you can see fluoroscopically here, this is the outline, the shadow of the MAC that you see. This is their prior aortic valve replacement. And so with that valve in place, a nice TAVR prosthetic without any significant mitral valve regurgitation. As you might expect, this is a pretty anatomically intensive analysis to make. There aren't a lot of patients that really fit well for this. As a result, a lot of those transcatheter MVR dedicated devices are having nested registries within them, within their trials, to take care of patients with MAC and mitral valve stenosis. So that is again, important possibility for a lot of our patients. This is a patient we treated a couple of months ago with Abbott's Cephea device. Again, you can see here significant calcific mitral valve disease, mean gradient 14 millimeters of mercury. The only part of the valve that opens also doesn't really close properly. And so with this device, it's a self-expandable platform deployed in the ventricle, and then the atrial aspect is deployed. And you can see here, this is where the mitral valve annulus is. That's how the device really sits into place with, again, a nice result as you see there. Ultimately, all these TMVR devices, as I implied in the prior slide, are still relatively early stage devices. Edge-to-edge repair has been affected worldwide, and I think by now almost 140,000 cases. We've been doing it here for 15 years. So these are devices we're really using in very niche applications for patients who we don't think are anatomically suitable candidates, either for surgery or for transcatheter edge-to-edge repair. So what can we do for patients who've undergone a mitral valve surgery previously? Again, we still think about edge-to-edge repair quite often. This is a patient with a 78-year-old gentleman with a prior repair using a posterior band and neocords. You can see now he's got still, this happened earlier, Katie, and then I think I X'd out of it and then went back to the slideshow and it let me play the videos. There it is. So you can see here recurrent posterior segment flail, associated anteriorly directed MR. Now again, if we analyze this very carefully, what you can see is with the grasping plane across the area of the pathology, you can see here a nice segment of P1 tissue. We put the color line on there, the color on there just to know that that's exactly on the line of our pathology. Mean gradient is only 3. So when we look at this from a 30,000 foot view percutaneously, number of favorable factors here for clipping. There's adequate leaflet tissue, it's close to the commissure, we have a low starting gradient, so we don't think we're going to close up that orifice too much. So again, here you've seen a lot of these images already, but here's the clip positioned above that area of pathology. And then once we go into place, we can be very granular in understanding from our imagers exactly what we're doing and where we're doing it. And we've left the patient with no residual mitral valve regurgitation. More complex pathology and how can we really sort of use all of the imaging that we have. Here's a patient, 79 years old, a prior band about a year ago, no significant mitral valve stenosis. The valve leaks kind of, as we see here from the 3D understanding, sort of at the medial aspect of A2P2, as you see there. That becomes a very relevant understanding momentarily. When you look at this and with a grasping plane, you can't really tell whether there's posterior leaflet there. Can we grab onto something with the MitraClip? Whether it's because there's no leaflet from the surgical repair or whether it's just shadowed out by that band on the echo is very hard to know. So we often bring these patients for a CAT scan. You can see that as we slice the valve at about A2P2, again, where we know that it leaks on the echo, we can actually see a really nice posterior mitral valve leaflet there, moving in systole and diastole as you would anticipate it would. And that leaflet measures just over 10 millimeters, which is an appropriate length for us to grasp. So on the basis of this, along with the echo, we can go ahead and bring this patient to OR81. Here's that MitraClip positioned at that medial aspect of A2P2. Again, can't really see that posterior leaflet. We believe it's there based on our CAT scans. You can see here, again, grasping the anterior leaflet. And then as we pull the clip arm up toward the posterior leaflet, get it away from that shadowing posterior band, you can actually see here this posterior leaflet flipping around really nicely on our MitraClip arm. And then once we grab onto it, a nice result of that tissue bridge between anterior and posterior and really trivial residual mitral regurgitation. So I think this is an important thing to think about. A lot of times we don't hear about these patients because there's an assumption that if they've had a surgical repair, we don't have a good transcatheter option, but certainly something that we can do. We did look at, these are again very small, anywhere between 6 patients and 104 patients. These are small case studies or registry data. But we did a little meta-analysis of this recently, and you can see that about 75% of patients are left with 1 plus or less MR after a procedure like this, a clip and ring. 90% of patients 2 plus or less MR. Importantly, NYHA class substantially improved after clipping, all with an in-house mortality of about 1.3%, which of course would be a significantly higher expected mortality for a redo surgery in a situation like this. For those patients in whom a clip and ring is not a suitable alternative, like we've done valve and MAC, we can also do a valve and ring. This is a patient, 82 years old, EF of 25%, a prior semi-rigid ring. For our surgical colleagues who are aware, this is the semi-rigid ring is a great platform for us to put a TAVR in, and you'll see why in a moment. This patient now has significant mitral valve stenosis. Again, you've seen enough of these now in the last 25 minutes, but we place a balloon expandable TAVR valve into that ring. What I'd point out is that the semi-rigid ring is great because it tends to circularize a bit. It allows the catheter valve to really expand out to the recesses of the commissures nicely, and I'll draw a distinction to that in a moment. But now here, an excellent treatment under conscious sedation for this 82-year-old with LV dysfunction and previously severe MS. What are more complex things that we can do in this kind of a situation? 74-year-old prior rigid ring, so that's an important distinction that I'll show why in a moment. Severe recurrent mitral valve regurgitation. And if you look at this anterior mitral leaflet, you can see it's very long, it's very floppy, it's actually already touching to the ventricular septum. The reason that's a problem is when we put a valve in ring like this, the anterior leaflet is just going to drape over the transcatheter heart valve frame, and if it's this long, it can occlude flow out the LVOT. So this group of collaborative investigators between the NIH, Emory, Washington Hospital Center came up with this procedure called the lampoon, where if you have the native leaflet there that's obstructing the LVOT, you just lacerate it, and then it splays to the side of the transcatheter heart valve frame, and then allows LVOT flow. So this view that you see is from the aorta. So this is what we did for this patient. You can see here a catheter from the left atrium, a wire going out and snared up into the aorta. This has been sort of crimped to make a cutting surface, and then after we apply RF energy to the back of the wire outside the body, we can just pull that through the anterior leaflet. It creates this laceration, as you can see there, and that allows us to put our TAVR into position. Again, this was a rigid ring, so you can see here gaps or spaces at the posterior medial and anterolateral commissures of the ring. So then we just put in some plugs to fill in that space. And then, so these are, again, more complex valve and ring procedures, but also I think that reflects what the data is going to show you. So this was the TVT registry in which both Dr. Kapadi and I were involved. About 800 patients who underwent a valve and ring procedure. STS score was over 8%, so again, a very high-risk group of individuals. You can see here out to 1 year, 92% of patients were left with mild or less MR. Mortality at 1 year of 22%, I think, reflects a pretty high-risk group of patients, although in fairness, 30-day mortality was just over 5%. So again, a complex procedure, complex sort of anatomic substrates for these patients. They did very well from both an NYHA class perspective, and also, of course, those patients who had a technical success did better than those who did not. Importantly, when you look at these patients ranked by STS score, those patients in a lower group did much better than those patients in a higher group, both initially and out to 1 year. I would caution that I don't think looking at STS score in a trial like this reflects truly low, intermediate, or high surgical risk, because by definition, all of these patients were high surgical risk patients. That's the only indication for this procedure. So I think it's more relevant to say STS score is a function of their comorbid baseline states. What can we do for patients who have a degenerated surgical valve replacement as opposed to a ring? So this was actually a benchmark study from a large institution of 250 patients, average age 63 years, STS score of 6.7%, with an in-house mortality of redo MVR, isolated redo MVR, of just over 9%. I would be remiss if I did not include our surgeons' data in this regard. This was a paper published a few years ago. 133 patients who underwent an isolated redo MVR, similar demographics, with an in-house mortality of 0.75%. So again, as I showed earlier on the mitral valve repair for primary MR slide, where you go really matters. Having said that, even in our institution, for those more complex patients, not just isolated MV replacement, redo isolated MV replacement, but redo MVR with something else, tricuspid, AFib, CABG, what have you, STS score higher and in-house mortality higher. So these redo operations, I know, Tariq and I and Dr. Madeir and I, Dr. Yelanov and I have had a lot of conversations about a lot of anatomic complexities in these redo mitral cases. So it's good to have a transcatheter solution. So this is probably the most common non-TAVR application in which we use the TAVR valve is valve and valve replacement. So there's a 76-year-old, an 8-year-old number 27 CE valve. You can see here significant mitral valve stenosis, a mean gradient of 18 millimeters. And again, pretty typical. This is a conscious sedation procedure, 45 minutes. The patient usually goes home the same day. You can see here a final mean gradient of 3 millimeters of mercury. We looked again at the TVT registry, Dr. Kapadia and I, in a multi-center group. This is an average age of 72 years, again, very high-risk group, STS score 9.2%. What you can see here is actually excellent safety in those patients with a low sort of comorbidity index, an in-house mortality of 0.4% for this procedure. As patients got more sick, of course, they did not do as well, both in the early and in the midterm out to 1 year. You can see here nearly 100% of patients had no real residual MR. What I would point out is that the mean gradient here is still in the range of around 7 to 8 millimeters of mercury, which I think is not ideal, but I think part of this also is reflective of ultimately limited experience if you just look nationwide. In 2021, there were 300 centers that performed a total of 915 of these cases. Not a high average. In the last few years, we've generally been doing somewhere in the range of about probably 40 to 50 of these cases annually. So with that experience, as we have in most of our arenas at Cleveland Clinic, we're able to understand a bit better and try to make the procedures better. So one of our first publications for mitral valve and valve looked at our experience in doing these procedures under conscious sedation. Again, pretty comorbid patients, general anesthesia, endotracheal intubation is not nothing for them. And so we showed that in this group, we can do conscious sedation, mitral valve and valve, really quite safe and feasible. We then went to how can we optimize the hemodynamics from this. As I showed you on the prior slide, in that national registry, the gradients were at 7 to 8 millimeters of mercury on average. What we've shown, and the pioneering work on surgical valve fracture was really done by one of my classmates in fellowship, Adnan Chatrawala, and his surgical colleague, Keith Allen, who are at Mahi in Kansas City in the aortic position. So we applied that to the mitral position. You can see here where this THV and the surgical valve meet. There's a pretty significant waste. As we crank that balloon up further and further, you see the surgical valve frame fracture provides a much better opening of the transcatheter heart valve. And with that, you can see a much better hemodynamics, a drop in almost 2 millimeters of mercury in the valve gradient. Potentially, valve durability is a bit better with that out to 1 year in terms of regurgitation, just because the THV opens better and the the catheter leaflets can open more appropriately. So again, as a group, I think we've been able to kind of forward what the data is for these kind of procedures, just based on the amount of patients that we take care of here at Cleveland Clinic. This is a more niche-y and interesting procedure we've been doing lately. Just as I showed you previously in that mitral valve and ring application where the native anterior leaflet can flip out and cause LVOT obstruction, you can have a similar situation in patients who have a mitral valve prosthetic, where that anterior leaflet of the prosthetic in someone with a small LV or hypertrophy of the septum can also occlude. So while you can do the lampoon procedure for that I showed you earlier, this is a procedure that we've developed more recently. We puncture the base of the prosthetic mitral valve leaflet with the wire here. You can see that wire then at the base of that anterior leaflet. We then dilate the leaflet a bit to separate it from the surgical valve frame. You can see that there, still kind of hanging on at the commissural posts of the surgical valve. And then we actually implant the transcatheter heart valve into that position. So then we implant the transcatheter heart valve, this is again a SAPIEN 3 valve, into that. And what it does is it essentially splits the mitral leaflet. It does still hold on to the surgical posts you might see just down at the corner there, but the entirety of the LVOT portion of that surgical frame, there's no leaflet, again, allowing LVOT flow. We've submitted our initial experience with this after doing some of this benchtop work with the translational laboratory at St. Paul's Hospital in Vancouver that does a lot of this type of benchtop work. And finally, closing out, paravalvular leak it's an important problem for a relatively small group of patients, but in the mitral position, the incidences are probably somewhere around 10%, depending on the surgical series that you see. In the aortic position, slightly less. Again, this is not robust sort of surgical data, but at least what is there in the literature is when patients get operated for PVL as a redo, the recurrence rates of PVL can be anywhere from 10 to 40%, depending on the sort of native pathology, whether it was for MAC-related disease, endocarditis, things like that. I think, actually, to be honest, I think if our surgical group were to look at the literature, I'm certain it would be much better, and it may be an important contribution in that regard. Having said that, these tend to be relatively, again, sicker patients who have undergone a surgery, maybe bad protoplasm either for another surgery or may not want to have another surgery. And I think we can provide them a very successful transcatheter option. So these are the devices that we use. These are the Amplatzer vascular plug family of devices used in kind of an off-label fashion in this application. You can see here a patient that surgeon I treated just 2 weeks ago, a mechanical mitral prosthetic. You can see here 4 leaks really around this valve, one here anterolaterally, anteromedially, sort of posteriorly, and posteromedially. After we placed 7 plugs around this valve without any effect on the mechanical valve discs, you can see now really trivial residual mitral valve regurgitation. There are a couple of devices, again, approved in the US. This is the AVP3 device, which is approved everywhere except the US, and we're involved in the the international registry trial for this. We can only enroll about a third or maybe a quarter of the patients we actually treat with this in this registry. Nevertheless, we are actually the highest enrolling center for this device in the US and the second in the world, actually. So again, I put this up there just to say, really in every facet of mitral valve intervention percutaneously, we do have the ability not only to look at our own data, but really to be involved in a collaborative way nationally and internationally, just to make sure we're doing the best we can for the patients that we see here in Cleveland. So to summarize, I think contemporary imaging and devices really allow us to fix pathologic states that were not previously possible with the same degree of efficacy. I think next generation devices for native mitral valve disease are currently under investigation and I think appear very promising. Patients who have previously undergone cardiac surgery for mitral valve disease are often well suited to one of the various transcatheter treatments that we have available. Importantly, all transcatheter therapies are rigorously assessed through randomized trials, national registries, and/or collaborative multicenter studies to ensure safety and efficacy. Our group is certainly proud of the collaborative achievements we've made, both clinically and academically, in taking care of these patients. Certainly, all of you send us patients, and we appreciate that trust that you place in us to take care of them. Thanks very much.
Absolutely great. Thank you for doing this. Fantastic, and I'm very glad all of us got to listen and see the fantastic work you guys are doing. This is open for discussion. We have a lot of time to discuss, which is good. I can start off with, I was intrigued by the lampoon and the laceration business. Can you comment about we hear this term suicide ventricle. What is that? How do we handle that? And how is it relevant in the current setting as the other folks are getting teed up with their questions?
Yeah, so that is, I think there are 2 sort of pathologic states there in this kind of suicide ventricle idea. One is actually both are situations that Dr. Sandir and I discuss, unfortunately, too often. So there's work that you and he and Debbie and others have done, 10, 12, 15 years ago, looking at how the ventricle kind of changes in patients as they age, and with aortic valve stenosis, the aorta gets more horizontal. They tend to get an asymmetric upper septal hypertrophy. And then when that happens, they may or may not have active sort of LVOT obstruction or SAM. So then when we relieve their aortic valve stenosis, if they have an underlying sort of SAM or proclivity towards SAM, they can then get LVOT obstruction. And if we don't think of these things beforehand, we might be doing urgent things like a septal ablation at the time, along with sort of the anesthetic management that comes for LVOT obstruction to make things stable. So that's one scenario which in many ways is somewhat predictable based on assessing the preoperative data and addressing it up front before we ever do a TAVI, so to do a septal ablation or something like that. The more difficult scenario, and it tends to be the elderly woman who has AS, some degree of calcific mitral valve disease, ventricular hypertrophy, and then in that setting of all of it, a small ventricular cavity. Whether or not they have sort of a mid-cavity gradient or not, these are the patients that get really worrisome. When you look at their apical views on the echo, it's an obliterative cavity, and you think, well, maybe they're keeping that cavity a little open because they have AS, and when we relieve the AS, is that ventricle just going to become this suicide ventricle? So we look at those patients very closely. Sometimes if we think maybe the hypertrophy is a little bit more isolated, not just a mid-cavity obstruction, but there's something in the LVOT, can we also do a septal ablation there? If sometimes we can't tell, we bring them for an invasive hemodynamic study, and then based on that, if we truly have ventricular level obstruction, we can do a balloon aortic valvuloplasty. Some sense maybe that lets them sort of ease into it a little bit. And then if they tolerate that without a suicide ventricle, then we can actually do a TAVI and then bring them for treatment.
Thank you. Anand.
Your comments on MitraClip, just adding on to what you just said, for HOCM patients, inoperable HOCM patients, along with septal ablation, or even for a suicide ventricle, would a MitraClip work in that situation?
Yeah, so there's small registry data on using a MitraClip in patients that have SAM. We've done it before, again, in this same application, and the idea is simply it doesn't, because you grab that anterior leaflet that's a little bit lengthy, and also it's now weighted, it doesn't tend to SAM as much. We tend only to use it for somebody who might have, maybe they've already undergone ablation, it wasn't adequate. Maybe they have LAD stenting, so we can't get into a septal, or the cabbage and their LAD is occluded, so we don't have a septal access. So we tend to reserve the clip in HOCM for a very, very niche group of people.
Thank you. Nick.
Fantastic talk, and congratulations to you, Serge, and the team. Amazing work. That was one of my questions, so thanks for answering that. One comment, we put a lot of these aortic valve biologic prostheses. Now we're putting them in like 10-year-olds with the idea that we'll do valve and valve for forever. Same in the mitral. And we don't have any studies that take the really long view, 30 years, and look at all the different interventions. And there's data from the Mayo Clinic, from Joe Wu out of Stanford, that when they study patients with mitral valve, with mechanical valves, their outcome, and obviously their registries in retrospect, are better than with biologic prosthesis. First question, are we overdoing the use of biologic prosthesis and valve replacements is the first question. Should we put more mechanicals in?
Yeah, I mean, that's a tough question, right? This paper is showing, sort of better outcomes for the mechanical patient. It's always hard to know because there's clearly selection biases and patients that can tolerate anticoagulation versus those that cannot, and so forth. I imagine there's always a pendulum swing to these things about who gets what, and at some point it centers appropriately. I guess what I would say from a 30,000-foot view, right, is that all these patients we have a conversation with as cardiologists, as surgeons, get the patient involved to understand where their heads are at in terms of long-term anticoagulation for mechanical prosthetic, and also the realities of having a mechanical prosthetic. Is it really a lifelong valve, or is it kind of last 20 to 25 years, at which point their only option in the current era is a redo surgery, right? So I think once you put all of these into the equation, if they end up with a biologic valve at the index surgery, I think what's super interesting is what do we do at the next time? Because we can't keep putting transcatheter heart valves into a space, right? It gets smaller and smaller. To your point, the long-term data is not necessarily there. In the aortic position, we're just finishing up a TVT registry on 14 and some thousand patients in the aortic position that has encouraging data on durability out to 5 years, and hopefully it will finish up the paper and get accepted soon. But in the mitral position, I don't know what it means. Those leaflets could thrombose, those leaflets could degenerate. And so for the 58-year-old, does it make sense to have a redo surgery now, wait until they're 70, get a valve and valve? Or do they say, look, I need, I can't take 3 weeks or 4 weeks off my job. I need to earn for my family. I'll just get a transcatheter valve now. You can do a redo surgery when I'm in my late 60s and I'm retired. And I don't think the risk is going to be that much different, at least in our surgical experience here. And so taking the patient factors into play, I think, are becoming more and more relevant.
No, great answer. You know, the data on the mechanical valves it's very infrequent that they're reoperated on. And the data on the biologic valves, at least a third of the patients going forward end up on anticoagulation for atrial fibrillation and other reasons. So it's really a complex problem worth the heart team discussion. These severe MACs, do you look closely for liquid calcium? And if you see a lot of liquid calcium on the CTs, does it change your management? When we deal with a lot of MAC, there's a lot of material that's loose in the ventricle when we worry about embolization. Do you do any embolization protective devices in the severe MACs when you deal with them?
Yeah, so it's a really important point. So sort of the second point first about the embolization risk. So for transcatheter aortic valve replacement in all of its forms, valve and valve native, et cetera, we're huge here on embolic protection. We use it for all of our cases. Nationally, it's less than 15% based on some nuances of the data, but we feel strongly about it. So as a result, and because of the very, very low stroke rates we have in TAVR, we feel very strongly about it. Similarly, we use it not for our MitraClip and stuff where the stroke rates are low. It's not, again, calcific disease. For MAC cases, whether it's valve and MAC, a dedicated TMVR device for a MAC patient, et cetera, we do put a cerebral embolic protection device, and as a result have had very low to, frankly, negligible stroke rates as a result. So I think that's a really important point. The sort of that liquefied or calcific mass, and Serge and Rhonda and our CT colleagues, Dr. Desai and others, show us these super ugly pictures. It's hard to know how good of a scaffold that is to put in a valve and MAC. And I'm sure it's very hard, but it's also not very hard, and that's the problem. We have not done a case like that because they've just been anatomically unsuitable from an LVOT perspective or size of the annulus or what have you. And I'm thankful for that because I don't really want to find out about it the hard way.
And also often it gets hard to identify whether it is liquefied MAC. Often, we don't recognize it till we hear from the surgeons post-operatively that it was indeed liquefied. Any work going on in metal valves in terms of valve and valve? I mean, like a TAVR for a metal valve. What's happening, you think? How do you think 20 years down the road that field will look?
Yeah, it's an interesting point. There are very case report kind of series on this. To your point, Dr. Smadira, about worrying about embolization. So there are cases both in the aortic and the mitral position where you can go in and you can use a balloon to just fracture the prosthetic discs completely. There's a lot of embolic material that happens as a result. There are ways to address that to some degree. You can put, again, cerebral embolic protection devices in. Some people have actually used a very large Watchman in the aorta. That's the left atrial appendage occlusion device, again, to capture any debris that might come, and then to put in the transcatheter heart valve into that metal frame. These are obviously extremely one-off scenarios. Having said that, I wouldn't completely discount it, only because hemodynamically, right, it's a great result. It's a great platform. It's a great scaffold to put a THV. But the embolic protection field is moving along at a rapid pace. The current device we have, the Sentinel device from Boston Scientific, goes through the wrist. There's a filter in the innominate, and there's a filter in the left carotid. So it leaves the left vert open, and the pore size is still larger than we would like it to be. There are currently, and I can think of off the top of my head, 5 devices that are in or starting clinical trials. I'm the PI of one of them, where we put a filter device from the leg. It's basically a sock. It starts in the top of the ascending aorta, and it covers the entire cerebral vasculature, even down to the thoracic aorta. The pore size is very, very small, really just enough to let blood go where it needs to during that time. So if you think about sort of a total embolic protection, you probably worry a little less about the debris you're going to create. So to your future point, I think there's probably some hope there. At the same time, it's going to start out in very sort of prohibitively risk patients that we would ever do it, right?
Yeah. Obvious. Yes, but there's hope and there's work. Any other questions?
I have a question. So Amar, like you said, it looks like, obviously this is a complex issue. We're blessed with having experience. Looks like we're having low volume operators doing things because they're so niche around the country. Is there any way we can, to ensure that these are done responsibly, or is there a concern that low risk patients are going to be done with these devices because it can be done, and how is that going to be monitored?
Yeah, super important question. It's frankly a very controversial question that comes up in different conferences. You can look at it really in two ways. The bottom line is, I agree with you. These are complex procedures, and it's not just from an interventional perspective, right? It's all the management that surrounds it. It's the imaging that surrounds it. It's everything else. And to have that level of expertise that we have in each of these ways, that we have the luxury of having in Cleveland Clinic, is really applicable to very few, if any, places around. Having said that, patients can't always travel, whether for financial reasons, insurance-based reasons, logistic considerations, etc. We know that there are patients, even in Ohio, that don't travel to see us because it's too difficult for them to do so. So the ability to have some treatment options near where they live, as opposed to nothing, may still be an appropriate sort of mental calculus for a given patient or the referring provider to make, right? So I don't think we can concentrate all of these things to just a handful of places. Having said that, the most niche of the things, I do think that operators and clinicians have some degree of personal responsibility and will often refer things to more specialty centers. The device companies actually are quite responsible in this, to be honest, about both the educational programs that they have, as well as deciding where things like transcatheter mitral valve replacement, or on the tricuspid side, these therapies go to be analyzed in the real world setting before disseminating more diffusely. So I think it's you could see the answer on both sides of the coin.
Thank you. This is actually, I'm very thrilled with the crowd presence and the engagement and very high quality presentation. This is, we often hear from outside speakers, but we have some major superstars here. We should always remember that. Thank you, Amar, for doing this.
Thanks, everyone. Really appreciate it.